Hello, good morning, everyone. Welcome to 2020 Dissemination and Implementation Short Course hosted by University of Wisconsin-Madison. Today is day 2 and our topic is integrating implementation strategies and context. I'm going to go through the logistics for today. So I'm Mondira Sahamul-Downey. I'm the manager for the Dissemination and Implementation Launchpad at the University of Wisconsin-Madison. Couple of things to remember. Your videos and sounds are going to be turned off. Please use Menti or chat to communicate. Our conference code is in Menti 825854, 825854. And in the chat function at the bottom of your Zoom screen, please choose panel and attendees. So all your chat questions or your links that we would like to share with everyone is posted there. So feel free throughout the day to paste the links to any citations as you see pertinent as the day goes on. We will have breaks today, so please take advantage of those. All times are going to be indicated in US Central Standard Time. And if you are on Twitter, if you could tweet at hashtag ICTR_DI20. Again, hashtag ICTR_DI20. Those who are going to stay for the whole day will be entered in a drawing to receive a 1-hour consult with Laura Schroeder or Byron Powell, our esteemed guest faculty today. And this will be announced in 2 weeks. And I would like to thank all the speakers and volunteers who have helped to host this conference. Our agenda for today, in the morning, Dr. Andrew Kwanbach is going to take you through what we learned from yesterday and also introduce to what we are doing with dissemination and implementation at the University of Wisconsin. He'll then introduce you to Dr. Byron Powell, then we'll have a short 15-minute break, and then we'll have our case study panel from 11:30 to 12:30 for an hour or so, Central Standard Time, and then we'll break for lunch, and that will be the end of the general session. And then in the afternoon, we'll have interactive breakout groups so that you all learn how to use the frameworks or the information that you learned from earlier today. So links for those have been sent out to you. These are all individualized links. With that, I am going to turn it over to Andrew. Welcome, Andrew.
Hey, thanks, Mondira, and good morning, everybody. My name is Andrew Kwanbach. I'm an assistant professor in the Department of Family Medicine and Community Health at the University of Wisconsin. I'm also on the D&I research faculty at our institution's Clinical and Translational Science Award. But first and foremost, I identify as a systems engineer. I got my PhD in health systems engineering from UW-Madison in 2012 before coming onto the faculty of our medical school. I got a K award in 2015 that was dedicated to building a research career in implementation research by applying tools and principles from systems engineering. So the federal government, if you look at this report here, Building a Better Delivery System, has been calling for greater partnership between the professions of engineering and medicine for a long time. This joint report from the National Academies of Engineering and Medicine came out in 2015. So now that we're in 2020, it hasn't quite been 17 years, but we are starting to see more and more adoption of engineering approaches in healthcare and in implementation research in particular. Next slide, please. So people, especially in the medical field, often ask me, what's the connection between engineering and what are you doing in working in medicine? And here's, I think, the best and simplest idea I can convey about what I think engineering is all about. Engineers really learn about science and then leverage what we know about science to make products and services and systems that are useful to people. It's really as simple as that. So in that sense, I think there's a real affinity between the core principles of engineering and implementation research. Next slide. The University of Wisconsin has quite a proud tradition in this area. My PhD advisor and career mentor, David Gustafson, shown here, has been applying engineering principles to healthcare all the way back to the 1960s. I'm thrilled to learn in the last few weeks that the university's Department of Industrial and Systems Engineering just received funding for an endowed chair in Dave's name, so his legacy will live on. And I'm aiming to carry on that legacy in my own small way by founding the Implementation Science and Engineering Lab here at UW, where we're focusing specifically on implementing evidence-based practices for the prevention and treatment of substance use disorders in primary care settings. Next slide. So for the rest of the short course, you're going to be hearing from some really dynamic partnerships between doctors, nurses, and engineers shown here. It's really a hallmark of our institution, this engineering medical partnership, and hopefully we'll see more of it in the field of implementation research going forward. Next slide. So a very brief recap from day one. We spent some time kind of going through the chat and Menti comments about key points, and here's some of the things that we heard. Using the CIFR framework to assess context and implementation research and determine core components is really important. We heard a lot about embracing complexity, the importance of understanding context, and around context, how we can use our understanding of context to inform study designs and also design implementation strategies. We heard a lot about the importance of involving stakeholders. We heard about the need to adapt when necessary and also to document changes for replication purposes. And then really importantly, looking ahead, it's imperative that we integrate an equity lens and equity focus for implementation research. So those are just some of the things that we heard. Thank you for all of your input. I thought it was a great interactive first day. I'd like to encourage everyone to continue submitting your ideas and questions using the chat feature in Zoom as well as Menti. All right, next slide. So without further ado, I'm thrilled to introduce my friend and colleague, Byron Powell. Byron, it's time for your hat. Byron and I first met in 2015 at the Training Institute for Dissemination and Implementation Research. That year it was held in Pasadena, California. That was fitting because Pasadena is where the Rose Bowl football stadium is located. One thing you might not know about Byron is that he and I had crossed paths before at Camp Randall Stadium, which is the Badgers football stadium in Madison. We both spent a lot of time there as little kids. Byron grew up in the Chicago area, and his family has been coming to Badger games for his whole life. I'm from a small town named Watertown that's about an hour from Madison. My dad was a physician serving a rural community that included Watertown, Hartford, and Beaver Dam, Wisconsin, 3 small towns in rural Wisconsin. My dad did his residency at Wisconsin and decided to stay on in the area ever since. He was a season ticket holder for about 45 years. We had a GMC motorhome that my dad would drive into Madison every Saturday during football season with a whole camper load of friends and family from the Watertown area. Those were some of the best memories from my childhood. So yesterday, Jane talked a little bit about the Wisconsin idea to kick off the short course. The Wisconsin idea is the idea that a university should, as its core function, serve the people at the level of the community, the city, the state, the nation, and the world. And I think that this D&I short course is kind of meant to reflect that principle. UW-Madison was really the center of my local universe growing up as a kid. And Madison is consistently rated Sports Illustrated #1 college sports town. If you've ever been here for a Badger football game, you'd understand why. Camp Randall Stadium draws people from all over the state and the region, and it pulses with positive energy. So Byron and I were fortunate to share in that kind of magnetic draw that a university like UW can have when we were kids, and we're still big fans and text during Badger games to this day. But anyway, on to our professional work. Byron has done truly outstanding work in implementation research, especially when it comes to implementation strategies. A lot of his work is becoming very highly cited and really core to the field of D&I research. Some of his most important work is on creating implementation strategy taxonomies like the ERIC taxonomy, and then working with Anola Proctor and other colleagues on guidance for specifying implementation strategies. I definitely use a lot of his ideas in my own work, and I'm looking forward to talking more about that later on today. So with that, Byron, go ahead and take it away.
Thank you so much for the introduction, Andrew. I love that we're wearing Badger hats right now, and that I just saw my colleague Tanya Enbin say "Go Badgers." This is a lot of fun. Thank you so much for the invitation to give this talk and to be a part of this training, and really appreciate you and the entire team at University of Wisconsin. So this has been a wonderful experience thus far. So it's my pleasure to talk about some of our work related to implementation strategies today, and really look forward to the discussion this afternoon. Just to start off with, I want to start with sort of where Laura started in terms of complexity of implementation, and just acknowledge that we have a growing body of evidence for what Hendricks Brown might call the 7 Ps: programs, practices, principles, procedures, products, pills, and policies. And in a group of this size, I know that all of you are interested in a wide array of interventions that could be implemented to the public good. And all of these are complex and have characteristics in their own right that make them more or less difficult to implement. I also want to acknowledge, of course, that though we think about in translational medicine, moving from bench to bedside, we know that often we move from bench to bookshelf. These are some beautiful bookshelves in Dublin, Ireland, of course, at Trinity. But unfortunately, many of the interventions and much of the evidence that we generate through our research ends up languishing on the shelf. We see that evidenced in a number of key reports from the National Academies, the Institute of Medicine, and starting with some of these landmark reports on your left, documenting gaps in quality of care. And these gaps in quality persist internationally today. And I think that's largely why all of us are here. And one of the reasons that we see these gaps is, of course, that we have many barriers to implementing these interventions well. And of course, Laura emphasized this masterfully yesterday through the Consolidated Framework for Implementation Research. This is another framework called the Policy Ecology Framework that emphasizes, though often in health, we might talk about sort of the clinical encounter and focus on what is going on there. We know that the clinical encounter is very much influenced by the organizational context, the regulatory and purchasing context, political context, social context, and so on. And so there are really multi-level barriers that we face to implementation that are important to address. We also know that these barriers stretch across multiple phases of implementation. This is based on a systematic review that we did that was guided by a framework called the Exploration, Preparation, Implementation, and Sustainment Framework that really documented multi-level barriers, again, that really stretch across phases of implementation. The other thing to point out here is that we found considerably less evidence for work at the sustainment and exploration phase. We focused a lot on implementation, but not necessarily on those earlier and later phases of implementation thus far. And so over 20 years ago now, Richard Grohl and Jeremy Grimshaw noted that evidence-based medicine should really be complemented by evidence-based implementation. And again, that's why we're all here, to generate evidence for the types of processes and strategies that can be used to move effective practices into routine care. This is sort of a simplified version of what you all have seen before, but again, thinking about different types of evidence-based interventions And then another type of intervention that we're focusing on here today, implementation strategies that can be used to address multi-level, multi-phase barriers and facilitators, and hopefully promote the types of implementation outcomes that we would like to see. So can we actually get people to adopt interventions? Can we get them to use them with fidelity? Can we think about things like penetration and reach across service systems? And then ultimately, can we sustain these interventions over time? And so when we talk about implementation strategies, we've defined them in our work as methods or techniques used to enhance the adoption, implementation, sustainment, and scale up of a program or practice. And we've often talked about different types of strategies. So focusing both on discrete strategies that involve a single action or process. So things like clinical reminders, audit and feedback, and supervision are examples of discrete strategies. And I'll just acknowledge here that even when we talk about discrete implementation strategies, these are often very complex interventions in and of their own right. More often than not, given the myriad barriers that we face in implementation, we're often using multifaceted strategies. So we're combining multiple discrete strategies, some of which have actually been protocolized and branded. So we're starting to see, randomized controlled trials, for instance, of specific implementation strategies. So Charles Glisson, for instance, has something called the availability, responsiveness, and continuity intervention, which is designed to improve implementation by improving organizational culture and climate. Similarly, Greg Ahrens has an intervention that's designed to improve implementation through the mechanism of implementation leadership. So really focusing on can we improve leadership to ultimately improve implementation? And this is overly simplistic, but I often show this just to demonstrate that with discrete implementation strategies, ideally the discrete strategies that we choose in any given implementation effort would be matched to the barriers that we see. So for instance, if there is a lack of knowledge, it might be that interactive education sessions is a very appropriate implementation strategy. If there's a perception reality mismatch, so for instance, if clinicians or other providers are thinking that we're already doing evidence-based practice, it might actually be helpful to administer fidelity measures and feed that data back to them in comparison to their peers. If there's a lack of motivation to implement evidence-based practices, it might be that something like enhanced rates for delivering a specific practice might be appropriate. And finally, if there are poor attitudes about evidence-based practices broadly, it might be that we want to use some sort of interpersonal implementation strategy, such as a champion or an opinion leader in a given setting. And again, since we're often using multifaceted implementation strategies and often even multi-level implementation strategies, we need to think about how these fit together synergistically. And there's a great paper I cite here from Brian Weiner called In Search of Synergy that really lays out sort of a typology of different types of multi-level implementation strategies. And this is just one example where these different strategies might converge in an effort to increase the adoption of an evidence-based practice. So for instance, at the clinician level, we might have online training for a given practice. We might also operate at the organizational level through a learning collaborative that allows organizations opportunities to learn from other organizations and also engage in organizational improvement efforts. And then we might also have a policy-focused implementation strategy, again, such as enhanced rates for a given practice. All of these strategies hopefully would influence a variety of proximal outcomes, one of which could be clinician motivation to actually adopt evidence-based practices. And again, we just want to emphasize that oftentimes we need multi-phase strategies. So the challenges that we face across implementation phases vary. And likewise, oftentimes the strategies that we use need to be specifically targeted to different phases of implementation. On the left, you see just an example of those different phases as they're conceptualized in Lisa Saldana's stages of implementation completion measure. And on the right, you just see a couple examples that I don't have time to delve into, but one is from Lisa Maya Jackson and colleagues' work to use a learning collaborative approach that really documents the types of strategies that they use at each phase of implementation. And then the paper on the bottom is a paper led by Kia Turner, who's now at Moffitt Cancer Center, that documents the types of strategies that were used at various stages of implementation that were actually associated with high and low performing pharmacies. And so we encourage you to take a look if you're interested in more about phases of implementation and how strategies correspond there. So there are a lot of challenges when we look at examining the literature for implementation strategies. One is the notion that we have this sort of Tower of Babel problem, and this is really consistent with a lot of fields, but certainly is true in implementation, that oftentimes we use the same word to talk about totally different things, and we use different words to talk about things that are essentially the same, which leads to the problem of pseudo-innovation, where we're not really creating new things, we're just sort of rebranding and repackaging things that already exist. There's also this challenge of poor reporting. And so this is something I'll talk about towards the end of my presentation in more detail, but oftentimes implementation strategies are not reported in enough detail that we could actually replicate them in research or practice. And finally, when we first looked at the literature, this was really about 10 years ago now, we found a limited menu of implementation strategies. So a lot of focus on training and sort of educational implementation strategies, but not much on other levels such as the patient, organizational, or policy level. And so one of the first things that we did is we conducted a structured review of the literature, and this was conducted with a multidisciplinary group of colleagues from Washington University. And we originally were asking this question about what are evidence-based strategies to move evidence-based practices into routine care. And facing some of the challenges that I highlighted on the previous slide, we realized that really a first step is actually just naming and defining implementation strategies, as simple as that. And so in this paper published in Medical Care Research and Review, we named and defined 68 discrete implementation strategies. And we sort of just informally, qualitatively grouped these strategies in these 6 different categories that you see here on your right. So some of these strategies were really focusing on planning for implementation. How do we gather the data, build buy-in, and really develop relationships to promote implementation? Not surprisingly, some were focused on things like educating and training for implementation, financing implementation. There were a number of strategies that focused on restructuring, either restructuring a physical environment or restructuring clinical teams in a way that would promote implementation. And of course, we drew heavily upon the quality improvement literature. And so a number of these strategies focused on things like plan, do, study, act cycles, audit and feedback, supervision, and the like, that really focused on quality management. And finally, a few of these strategies really focused on attending to the policy context. So what are sort of outer setting strategies that we could use using the CFR language to move the needle on implementation? And we thought that was a good sort of first step and hopefully is helpful to folks. And one of the things that we quickly realized was that these strategies, of course, were based on a literature review. They weren't necessarily informed by a broader array of experts in the field. And so we had an opportunity when we were approached by Joanne Kirchner, Tom Waltz, and colleagues at the University of Arkansas for Medical Sciences, who were doing some work through the VA. And we started this project called the Expert Recommendations for Implementing Change Project, which was really a multi-phase effort. First to vet the work on the previous slide with a broader array of experts. So we engaged in a multi-round Delphi process that allowed us to refine the initial compilation of implementation strategies. We also engaged in some work through a concept mapping study, which offers a structured approach to sorting and rating strategies and ultimately develops conceptually distinct categories of implementation strategies. And so the refined compilation that is from the Delphi process is shown here on your left. And I note sometimes in the journal Implementation Science, the best resources are hidden in additional files. And so I just note here that you might find additional file 6 of that paper to be most helpful and detailed in terms of describing implementation strategies. The paper on your right, that's led by Tom Waltz, is the results of the concept mapping study, which reports initial ratings of feasibility and importance, which those are two things that Maria Fernandez brought up yesterday as important when considering sort of what barriers to address and what strategies to use. Those can be important drivers of how we select implementation strategies. And this concept mapping paper also has the categories of implementation strategies that were derived from that work. We hope that this can be helpful in identifying building blocks of multi-level, multifaceted strategies. And that's whether you're focused on research efforts, for instance, if you're developing conditions for comparative effectiveness trials within implementation science, or whether you're an implementation practice or a policymaker and you're looking to identify potentially helpful implementation strategies. We certainly hope that it provides a common language for improving reporting in implementation science and addressing that challenge that I noted earlier. Although we know that there's probably, there's no international consensus on the types of terms and definitions that we're using in this space. And then finally, we also think it's useful to help track implementation strategy use, which I'll talk about a bit towards the end of this presentation, as well as assess fidelity to implementation strategies. So just like we assess fidelity to clinical programs and practices, we also often would like to assess fidelity to implementation strategies. We've been really pleased to see the ERIC taxonomy and related work picked up by federal institutes here in the US as guidance for implementation, some of which is more focused on research, and some of which, for instance, the SAMHSA reference here is really focused on providing guidance to practitioners. And more so have been pleased lately to see colleagues kind of pick this up and advance this work in various ways. And so on the left, you see papers from Clay Cook and Aaron Lyon, who have really asked the question about, okay, how does this taxonomy of implementation strategies apply in school mental health settings? And although our approach has been intended to be pretty generic and generalizable to a lot of different settings, they also demonstrated ways in which the taxonomy needed to be adapted slightly for that setting. Similarly, we have some funding from the WT Grant Foundation with Allison Metz and Annette Boas to see how do these strategies apply within child welfare context within the US, and particularly as they relate to technical assistance efforts in those fields. Laura Damschroeder, I should have mentioned earlier, Laura is intimately involved in the ERIC project. Should have given that shout out earlier. She also was involved in an effort through the Evidence Now project led by Deb Cohen and colleagues. And this paper from Cindy Perry really focuses on how the ERIC taxonomy could be applied across large scale implementation efforts. And importantly, they also found ways in which the ERIC taxonomy was lacking in terms of describing some of the strategies that they were seeing applied. And so things like identifying and really specifying workflows within implementation efforts was something that was identified in their sort of refined ERIC taxonomy. Similarly, a colleague from RAND, Alex Dopp, has recently published a scoping review of strategies for financing implementation efforts. And he built on ERIC and other taxonomies of implementation strategies to specify 23 different approaches to financing implementation efforts. I know that's one of the things that we often think is beyond our control, but I think that's a helpful paper to think about potential opportunities on that front. And then I wanted to highlight some work by Sherry Rogel and colleagues. Sherry's an MD at the University of Pittsburgh School of Medicine, and she's been doing a lot of work within a national effort to improve care for hepatitis C. And one of the things that she's done is actually turn the ERIC compilation into a survey to see how could we actually retrospectively assess implementation strategy use. And the first two papers that you see here are from that effort. and would urge you to take a look at those. And there's a third paper that's under review now that also extends that longitudinal analysis. So she's been able to empirically look at what are the specific implementation strategies that are associated with success in this national collaborative. And then this was brought up yesterday. The paper on the bottom is from medical care. Yao was the one that mentioned Ed Meach and his work using configurational comparative methods. This paper, led by Vera Yakovchenko, uses those methods to identify different clusters of implementation strategies that are actually sufficient for improving care. And so again, it really addresses sort of the complexity of implementation. It also really highlights this notion of equifinality, that there's more than one way to implement a program effectively. Just wanted to highlight some ongoing and planned work in this area. So one is something that Laura, I think, maybe alluded to yesterday, but we're working with Deborah Bingham at the University of Maryland to understand how can implementation strategies, like one, how can we take an equity lens to our implementation strategies to ensure that what we're doing is not exacerbating health disparities, and if there are ways to enhance them with that respect, how can we do that? And then two, what is missing from something like the ERIC compilation when we think about directly addressing systemic racism and really trying to take on some of these equity issues head on? And so we're excited to engage in that. This is just starting, so that's sort of, there's still a lot of conceptualization to be done in that effort. There's also work led by Sheena McHugh, who I know was on yesterday, from University College Cork in Ireland, to link implementation strategies with behavior change techniques, as described by Susan Mickey and colleagues. And I think that's a way of further operationalizing and specifying these strategies sort of theoretically. We also are doggedly persistent in submitting an R01 that keeps getting kicked back, but hopefully someday will be funded. This is an effort led by Kara Lewis, Brian Weiner, and involving some other great colleagues, where we're really focusing on how can we identify the mechanisms through which the strategies identified through ERIC work. And I'll talk a little bit more about that later on. And then finally, there's some work by colleagues in Australia and at Karolinska to think about how do these implementation strategies apply to sustainment, and then how do they also apply to de-implementation as we attempt to de-implement different interventions that are low value. I always just include a slide like this when we talk about something like ERIC, just to say there are, of course, many alternatives in the field. And so Susan Mickey's work with the behavior change technique taxonomy hopefully is familiar to a lot of you. That's a really highly cited body of work that is very granular in its focus. Similarly, there's another great taxonomy developed by Koch and colleagues and Maria Fernandez, who may or may not be on, was involved in this work to develop a taxonomy of behavior change methods. Both of these are really involved a lot of health psychologists, and I think do a really nice job of grounding some of these techniques theoretically. And so I would urge you to take a look at both of those if you haven't already. This is just to note that there's a growing body of evidence for implementation strategies. You're not necessarily meant to take in this whole slide, but I wanted to point out that the number of randomized trials for some of these implementation strategies is quite high and growing. So for instance, for audit and feedback, the latest count that I saw was 140 randomized trials, but there are still many trials of audit and feedback that are being conducted, and indeed international efforts to really advance our knowledge about how audit and feedback could be delivered optimally. And I'll point to sort of some sources of this evidence, but hopefully as this literature develops, we'll obtain more and more practical advice about how we can actually apply these implementation strategies. And I wanted to highlight one great example of this from Jamie Brayhout and colleagues up in Canada, who have published these 15 suggestions for optimizing audit and feedback. And these are just examples below, but for instance, things like recommending specific actions, providing individual rather than general data, providing in more than one way, so both textually, numerically, graphically, and providing short actionable messages followed by optimal or optional detail. And so these are just, again, practical suggestions that really come out of a really deep body of work through Cochrane reviews and other meta-analyses of implementation of audit and feedback. And hopefully we'll see more and more of that type of guidance. Also, just wanted to point you to, I think, some really great sources to assess evidence of implementation strategies. And two that I always really want to highlight are the Cochrane Effective Practice and Organization of Care Group, who's conducted a lot of different systematic reviews and meta-analyses of strategies. And then the Health Systems Evidence Platform, which is run out of McMaster in Canada. Health Systems Evidence compiles and actually grades systematic reviews and meta-analyses of implementation strategies. This is the screenshot you see on your right. You can actually look up specific types of implementation strategies and then find reviews there. And so I'm not positive how often that's updated, but it's been a really valuable source. So there's really increasing focus now on how can we actually select and optimize implementation strategies, and how can we tailor them to enhance their effectiveness. So there's a lot of strategies identified. It's not always real clear how we should apply them. I think there are a number of pitfalls that we face when designing implementation strategies in our work, and sort of traps that we fall into. The first is that we often fall into this train and pray approach, right? Or train and hope if you're not religious. We send people to educational workshops and the like. We hope that their behavior changes, but we know that this is really necessary but not sufficient ultimately. The other thing arguably that we do is we fall into the trap of the kitchen sink approach. We use a lot of different strategies, really intensive approaches, but actually there are reviews that suggest these approaches are not always more effective than even single component approaches. And two reasons for this might be that we actually are not addressing the specific implementation challenges or barriers that are identified in a given setting. Or in other cases, maybe we're using multifaceted approaches, but they actually all focus on a single level or barrier. For instance, they might all focus on things like provider knowledge and skill without addressing organizational or policy factors that might actually influence implementation more strongly. This is arguable, but I would suggest that we far too often use a one-size-fits-all approach, so that sometimes our approaches are not adequately tailored to the variation that we see in real-world contexts across settings. And then finally, Martin Eccles said we often use the Islagiat approach, which it seemed like a good idea at the time. And again, we're limited in terms of the theoretical and empirical development of the field. So there's not always super clear guidance on how to select and tailor implementation strategies. So Islagiat is not meant to be pejorative in this sense. I think a lot of us are doing the best that we can, but we just need better guidance on how to approach this. Just real quick for the sake of time, we've found in some of our studies that decision making in implementation efforts is not necessarily driven by evidence, theory, or best practices, and that strategies are not used with the frequency, intensity, and fidelity required. So just to give a concrete example of that, we think of something like clinical supervision. Oftentimes in children's mental health settings, clinical supervision is not delivered, or when it is delivered, it's actually really focused on paperwork and sort of administrative issues, and not focused on building clinical skill and giving practitioners the skills that they need to improve their practice. So that'd be an example of an implementation strategy that might be being used, but used without fidelity to its intended purpose. There's also been evidence that suggests even when we try to identify barriers and match strategies to them, there is often a mismatch between identified barriers and the quality improvement or implementation strategies that we use. And so we think there are a number of opportunities for enhancing the impact of implementation strategies. And I won't dwell on this slide. I'm going to go through these one by one quickly to approach some avenues that we might improve our work related to implementation implementation strategies. The first is really enhancing methods for designing and tailoring implementation strategies. So there is a Cochrane review that has provides some evidence that assessing barriers prospectively and designing implementation strategies to address them is more effective than more standard approaches. However, in this review, they also note that it's really not clear how best to tailor implementation strategies, and thus not clear what the effect of an optimally tailored strategy would be. And I think there are a number of opportunities to improve that. The first is something that actually came up yesterday. So we need better methods for identifying and prioritizing barriers. And this came up with in relation to the CFR. What domains do you focus on? Something like the CFR that already has 39 domains, offers a lot of opportunities for us to intervene. And the example that I actually often give with respect to this point is from the Tailoring Interventions for Chronic Disease study, in which they identified 1,200 different barriers or determinants of practice across 5 different interventions for 5 different chronic diseases. So you could imagine with 1,200 determinants, I believe 600 of which they deemed plausibly related to their outcomes of interest. There's a lot of work to understand how do we actually use that to inform intervention design or implementation strategy design. So we need more pragmatic approaches to help us to prioritize barriers. We also, I think, need adaptive strategies to address dynamic barriers. So one of the findings from that same study, the TICT study that I referenced, is that it might not be enough to actually design an implementation strategy that is responsive to barriers that were identified at baseline or prospectively, and not have a more adaptive approach. We know that these barriers are likely to change again throughout different phases of implementation. If COVID and all the challenges that we're dealing with in our society currently aren't evidence of this, I don't know what is. Things are constantly changing at multiple levels, and we need to address those things adaptively. And then finally, we also need systematic and rigorous methods. So even if we did identify and prioritize barriers, it's honestly not always clear what strategies should be used to address them. And to promote behavior change at various levels. So we've done a little bit of work to identify potential implementation strategies, potential methods for selecting and tailoring implementation strategies. And on the paper on the left, we've highlighted intervention mapping, or as we'll talk about, it's been repackaged as implementation mapping by Maria Fernandez and colleagues, and is really moving towards that angle. We also identified concept mapping, conjoint analysis, and group model building as potential methods. And we're going to be giving some more applications of this tomorrow. Laura and I will, but we're working in a variety of projects to apply and test and see are these different approaches feasible and effective in terms of helping us to more systematically design and tailor implementation strategies. Similarly, Heather Cahoon and colleagues at the University of Toronto and elsewhere have conducted a systematic review where they identified 15 different replicable methods for designing implementation strategies. And these really were focused on changing professional behavior. They found a limited focus on organizational and systems approaches within their review. But they identified these 4 common steps: identifying barriers, linking barriers to implementation strategy components, and then importantly, using theory and engaging end users, all of which are things that came up in our discussion yesterday. This is a project led by Laura Damschroeder and Tom Waltz that we're going to talk about in detail tomorrow, but this paper represents an effort to summarize that work, which was really to develop a tool to match the consolidated framework for implementation research to ERIC implementation strategies, such that if you did a context assessment with CFR, you could identify potential strategies that might be useful to address those barriers. I'm also going to spend some time, again, talking about intervention mapping, and as Maria Fernandez has recently written about, implementation mapping tomorrow. This is something that we're applying within a project here in the States as well as Vietnam, to see how can this be used to actually help us to tailor implementation strategies to specific sites. So the second priority that we identified is really focused on specifying mechanisms. And these are really, this is defined as the processes or events through which an implementation strategy operates to affect desired implementation outcomes. And I think this can end up seeming quite technical, but I think one of the simple ways to think about this is like, how can we develop logic models for our implementation strategies? And how can we start asking questions about how and why they work? So not really just generating dichotomous yes/no answers for did this strategy work, but how and why did it work, or how did it fail, and how can we optimize it moving forward. The diagram that you see is from a paper led by Kara Lewis that we published in Frontiers of Public Health a couple years ago, that really focuses on specifying specific mediators, moderators, and preconditions for implementation strategies that, again, is meant to demonstrate how it works to affect proximal and distal implementation outcomes, and ultimately clinical and public health outcomes. These are just some examples of this, and I may not go over every one of these, but again, if we have a determinant such as a provider skill deficit, it again might be appropriate to respond to this with training, so offering teaching and practice with corrective feedback. And that might operate through the mechanism of skill acquisition, refinement, and mastery, and ultimately lead to better fidelity to evidence-based practices. And the idea of focusing on mechanisms is that we really should be measuring things like skill acquisition, refinement, and mastery, and seeing, do our strategies actually work to address that? Similarly, at a sort of different level, if we think about something like turnover, which is a huge problem in mental health settings, and obviously a variety of other settings, it might be that a strategy such as train the trainer operates by providing more continuous on-site expertise that's available for consultation, and ultimately addresses a more distal outcome like sustainability of a given program or practice. So again, the point here is just that we really should be starting to specify how and why these strategies work, even if it's conjecture. So even if you can't rigorously study it within your implementation research or practice, I think it's good to specify these things so that we at least have common assumptions about how these things are working. We have the good fortune to have an effort funded by the AHRQ here in the United States that is partnered with the Society for Implementation Research Collaboration. And this is really focused on developing a research agenda for studying mechanisms and implementation research. And I have a link here to the website if you want to read more about this. I also have a link here to an opening webinar for this effort that was led by David Chambers, Nate Williams, and Kara Lewis, who's the PI of this R13 conference grant. And we're really looking forward to the work with that group, as I think there are a lot of challenges to studying something as complex as implementation mechanisms. Again, this is multi-level, it's dynamic, and so we need to bring a variety of methodological approaches to studying something like mechanisms of implementation. The third priority that I want to highlight is really focusing on conducting more effectiveness research. And so I already mentioned that there's a growing body of evidence for specific implementation strategies, but there's certainly a need to focus on this area. And one, I think there's a need to diversify the types of strategies tested. Again, there may, I think it's fair to say that there's been a bigger focus on sort of provider level implementation strategies and change efforts, but maybe need a little bit more focus on client level factors, organizational factors, and system level factors in our work. There's also a need to understand discrete, multifaceted, and tailored implementation strategies. So again, focusing on discrete implementation strategies, even something like audit and feedback, we're still working to understand what are the features of audit and feedback that really improve its impact on implementation and clinical outcomes, and how can that be optimized. And that's a really important line of research, because oftentimes those discrete strategies will be included with other strategies in multifaceted efforts. And so I think optimizing those discrete components is really important. When we think about multifaceted strategies, there is a real need to understand how do we actually optimize those packages? How do we select the component strategies that will be a part of multifaceted or multi-level strategies? And we might have time to talk a little bit on day 3 about specific designs that have been used for that. So for instance, sequential multiple assignment randomized trials or SMART designs have been used to see how can we actually develop adaptive implementation strategies that are responsive to the level of responsiveness at the individual or site level. So for instance, if an organization doesn't respond to a less intensive implementation strategy, we might need to ramp them up to a more intensive strategy. And SMART designs are one way of generating those types of adaptive implementation strategies. And then finally, we do need more studies of tailored strategies. So one, to know, are prospective efforts to tailor implementation strategies to organization or site specific needs more effective than standard approaches? And if so, is the added effort and burden of tailoring implementation strategies worth the cost? And so can we conduct economic analyses and really understand, is that worth the added cost? And then finally, on this front, we need to use a wider range of designs and methods. And again, maybe we can talk a bit about this tomorrow. But oftentimes, the gold standard for these evaluations are randomized trials or cluster randomized trials. But we know that they're not always feasible. And Hendricks, Brown, and colleagues have done a great job identifying a wide range of designs that could be used, both experimental and quasi-experimental designs that could be used in implementation science. And we need to actually broaden our use of those designs. This is, I'd hoped would be published, but I think is not yet, a paper led by Luke Wolfenden and colleagues in Australia, where we tried to provide guidance for designing and undertaking randomized implementation trials. And I hope this will be a really helpful paper for people at all levels. I really learned a lot from working with this group about conducting implementation trials. So the fourth priority is really to increase economic evaluations. And so since back in 2007, there was a paper that suggested less than 10% of guideline implementation strategy evaluations included an economic analysis. And this really inhibits our decision-making at the organizational and systems level. And those findings in 2007 have really been largely replicated in recent systematic reviews that you see here on the screen that just suggest we need a lot more economic evaluation of implementation strategies and bringing those tools to bear. My colleague Maya Barnett recently led this paper that really focused on how can implementation science and implementation scientists better collaborate with health economists to advance implementation science. And one of the things that we found was that health economists, of course, don't always want to be doing sort of simple economic evaluations of implementation strategies, but there are many opportunities to improve partnerships between implementation researchers and practitioners and economists that are highlighted there. There's also a learning community, for lack of a better way of saying it, that's led by Todd Wagner at Stanford University and the VA in Palo Alto. This is a monthly group that meets via Zoom and has a Slack channel that we use, or a Slack page that we use to exchange ideas in this area. And so would encourage you to plug into that if you're interested in advancing work in this area. And the final thing that I want to talk about is just this need for improving description, tracking, and reporting. There's poor description, again, in the field that really limits our ability to replicate these findings in research and practice, and ultimately precludes answers to questions about how and why implementation strategies work. And one example of this is from Aram Nadeem in a systematic review of learning collaboratives, where she found that reporting on specific components were imprecise across articles and basically rendered it impossible for them to identify what are the active ingredients of learning collaboratives that are important. And so we've developed some reporting guidelines. This is led by Enola Proctor and Curtis McMillan and I, where we suggest that people really need to name implementation strategies, define them very carefully, and then importantly specify things like who are the actors involved, what actions are they taking, what are the targets or mechanisms of those actions. Is there anything about the temporality or dose that needs to be reported? So temporality or sequencing of the strategy and how that interacts with other components. And then what are the implementation or proximal outcomes that the strategies are addressing? And finally, what is the empirical, theoretical, or pragmatic justification for using those strategies? And we're going to have a chance in our activity today to kind of go through an Excel sheet and specify some of these things with the strategies that you're applying within your studies or applied implementation efforts. And so you'll get a taste of sort of trying to identify some of these. And I guess the take home on the activity is that, do the best that you can with what you have right now. Some of you may have answers to all these questions. For some of you, there may be some work that you need to do to specify your strategies more thoroughly. I see Mandira, so I know that I'm out of time. So I will just say that there's some applied examples of this. And this is one from Alicia Bunger that specifies 11 components of a learning collaborative. But you'll also see an applied example from Andrew Quanbeck today as he shares his work. So this should be made clear. And you'll have the slides. These are some efforts to actually improve how we track implementation strategies prospectively and track things like adaptations to implementation strategies. So I'll stop there as I'm seeing all the screens turn on, which tells me that I'm in deep trouble and probably have been ignoring text. I apologize.
Excellent. Thank you so much. That was excellent information. And we can see that on Menti, so many people have some questions they'd like to ask you. So I'm going to start by just sharing some of the most popular questions. So I want to encourage people to go on and upvote on Menti. So the first question is, when using multi-phase strategies, how can you measure the effectiveness of individual strategies in an implementation trial?
Yeah, that's a great question. So I think in terms of measuring, the effect of individual strategies, I think that's very difficult unless you have a design like the SMART design that I mentioned that would actually allow you to test various components. SMART designs are really a variant of a factorial design. So for instance, Andrew, not to put you on the spot, but Andrew has a nice study of I believe learning collaboratives where you tested different components of learning collaboratives to see, which component is really driving the change. So I think variants of factorial designs is one way of doing this within implementation science. Did I butcher that, Andrew?
That's more or less correct. Some of the details I'm going to present on this a little bit later, but yeah, you can. SMART designs do provide a method where you could take a bundled strategy and kind of turn it into a series of discrete strategies that can be tested sequentially. So you can do kind of, you can look at the effect of different components of strategies that way. That's one possibility.
And the other thing I would add quickly is just with all of this stuff, with that question and with questions about mechanisms, et cetera, I think, the name of the game to me is mixed methods process evaluations. And so I think we can learn a lot from qualitative and mixed methods about how and why these strategies are working. And that's one way that we could look at individual components and see, what did people like, what was helpful to them, and how did these actually work in our implementation efforts.
Agree with that 100% too. The mixed methods evaluation is really essential to understanding kind of these mechanisms of how implementation strategies are working.
Yeah, and I just want to add to that, it takes time to separately or individually, set these trials up to really get at that detail. So just also really reinforcing the importance of qualitative and mixed methods work to help us really design trials that will give us kind of the most knowledge for the effort within a quicker range of time. And then the importance too of language and being consistent in our terminology and the way that we're conceptualizing. So Byron today, talked about implementation strategies, and those have a language and terminology of their own. And so it's very important for us so that we can build on one another to be consistent.
Excellent. That was a really thorough answer, and I appreciated that all three of you were able to provide some additional insights. So moving on to the next question, what's the benefit of using ERIC versus the behavior change taxonomy framework? Can you speak to that a little bit?
Yeah, and I forgive my irreverence, and I mean this not to denigrate any of the taxonomies, but I've said in previous presentations that they're just stinking lists of strategies. So like in my mind, all of these are ways to operationalize our implementation strategies, and we need not get too caught up on, and this is not to contradict what Laura just said about the importance of consistency of language, but I'm a little bit giving up on the consistency of language piece and really focusing on, I think, like reporting guidelines that force us to specify the specific things that we do in implementation. And what I would say about ERIC is that it's conceptualized at a little bit of a broader level. So I think in some ways, for instance, we put these in front of stakeholders. We put behavior change techniques, ERIC strategies, and the behavior change techniques identified through intervention mapping in front of stakeholders. They were on that level more easily able to grasp the ERIC strategies and sort of wrap their head around that. But I think the benefit of something like the behavior change technique taxonomy or the taxonomy developed through the intervention mapping group is that they are a little bit more specific, a little bit more, not a little bit, they're aligned to behavior change theory. So I think there is great benefit in potentially combining these approaches so that we have sort of a general description, but that the ERIC strategies could be defined more specifically using the behavior change techniques. And I think that's one way of thinking about how do we actually specify the mechanisms that these strategies operate through. So I think that's sort of one avenue. And again, Sheena's doing work, Sheena McHugh is doing work to sort of link these conceptually. And I don't know if Julia Moore is on today, but I know she was presenting a project where she's looking at ERIC strategies, but then also sort of how do they connect to Susan Mickey's theoretical domains framework and behavior change wheel, or COMB framework anyway, and sort of linking those in that way. So I think there's benefit to that linkage. Laura, correct my ERIC. I'm not meaning to
no, I think it's all both and all along the way. So having consistent language, like when we're talking about audit and feedback, we call it audit and feedback, but the devil is in the details about how audit and feedback is designed. And Byron made quick reference to reporting specifications that I think actually can be used to design and specify exactly, in the case of audit and feedback, I'm just going to use it as an example, exactly how it is operationalized. Who are the actors? Who are the target of the, each of the individual activities? And that's where the behavior change techniques can come in as well, is, tapping into incentivizing, tapping into action planning. Those are all very specific techniques that can be done and make perfect sense to kind of explicate those within this broader framework of doing audit and providing feedback as an overarching strategy. And
the devil's in the details is the best way to, I love that. So and I just want to highlight, Maria Fernandez noted in the chat that they've done some work to map ERIC to intervention mapping methods and practical applications. And there are many areas of synergy there that intervention mapping can be used to expand and create content and specifics for some of the more general ERIC strategies. And that's kind of what I would say is I feel like ERIC would at best be a starting place that then needs to be operationalized much more thoroughly.
Yeah, and Sheena McHugh goes on to say in the chat that, you know, there's some overlap, but really we can think of the behavior change techniques as ingredients within maybe a broader recipe of the strategies.
Great. So now I'm going to ask another question that builds on what you've in many ways already been talking about, and also part of your presentation about tailoring. So how can tailoring be done in practice outside the context of well-funded, expert-led research studies?
Yeah, so we're doing a study right now that I can share more about tomorrow through my KO1, where we're working with community agencies to tailor implementation strategies to their site-specific needs. And I think it was Yao that mentioned this yesterday, that sort of a lot of the theories and frameworks that we use are in the background, and that people in community settings don't necessarily want to hear that language. But I think we've found that the notion of you know, working with community agencies to identify their site-specific barriers and come up with site-specific implementation plans is actually quite intuitive, I think. And I think people do that all the time. They just rarely take the protected time to do that. So I guess my thought would be that you don't need a lot of funding from that. You could do that in a you know, within the structure of your usual meetings. You just need to take the time to dedicate to that process.
Yeah, I might just chime in on that one, that we're doing a study. Tailoring is kind of a specific focus, so it is an R01 level NIH study. I think the short answer is we don't have a lot of definitive answers on that question right now, but I would say that the best thing to do would be to just, you know, really actively engage stakeholders, try to understand, you know, what their needs are. And as the field is doing more and more of that, I think we're hoping that we'll learn more generalizable kind of lessons about specific tailoring kind of variables that are important to consider, and then, you know, how you would respond with different implementation approaches based on that knowledge. I think right now it is sort of the kind of thing that has to be done sort of conversationally with stakeholders, which is always important. And as we learn more and more through research studies, our body of knowledge should be increasing on that front.
I think related to that, Byron, I have a question is similar to how we identify the key elements of an intervention and the adaptable periphery. Do you think it's possible to identify the key elements of an implementation bundle for a given intervention that would help you with considering tailoring?
Yeah, and you know, it at least strikes me as similar to the first question that was asked, you know, that we may through smart designs and other factorial designs have a better understanding of specific components. There are also people that if you're familiar with sort of the common elements approach within mental health and other settings, the idea is that once we have you know, enough randomized trials that use, you know, specific strategies, we can cull from those randomized trials the common elements that are effective across studies, and then develop sort of more modular or common elements approaches to clinical practice. And I think that a similar analogy could be very useful in implementation science. And there are people that are working to advance that area. But I think the limitation that we come up to there is, again, reporting has been so poor, and we know so little about specific components of some of these more complex implementation approaches, that type of common elements approach is somewhat limited as we synthesize data across randomized trials.
Thank you. And now I have another question that I think is really interesting about, has there been any work done on cost effectiveness of implementation strategies in practice for a given intervention? It would seem the more expensive the implementation, the harder an intervention is to adopt.
Yeah, and again, I would just reiterate, and maybe others can add to this, there's not enough work on cost effectiveness of implementation strategies. And so certainly there has been work done there, and some of the systematic reviews that I posted on that slide could be used to identify some of that work. But of course, the part of the question that acknowledged it's going to be harder to get people to adopt expensive strategies is an apt one, and that's precisely why we need to do more of this work. It's also maybe a tangent, but I think one of the complaints about implementation strategies has been that we're replicating the same problems that we have with our interventions and our evidence-based interventions, and that they're often either too clunky and not user-friendly or too expensive. And so we're sort of layering on another intervention that could be clunky and expensive, then we're in trouble.
And I think with there's a difference between implementation strategies to bring on an intervention and get it going, and then to keep it going. And that can be an area for economizing as well.
Yeah, regarding cost effectiveness, I agree that it's an important topic. I'm leading two NIH funded R01 trials that we're doing cost effectiveness analysis in both. The best example that I have seen so far is from Brian Garner and colleagues using pay for performance as a cost effective, or testing the cost effectiveness of pay for performance as an implementation strategy. We are working on a special issue for the journal Implementation Science that's specifically focused on economic evaluation and implementation research. It should be probably released at some point in 2021, but I think the state of the field is such that there's very limited economic evaluation, and cost effectiveness analysis would arguably be sort of the gold standard, and very little of that going on. I think we definitely want to start with just making sure that people assess cost as part of their implementation strategy outcomes assessment, and cost effectiveness is going to be kind of a longer road. But I think the state of the science is quite thin there at this point.
The other thing I've seen people wrestle with lately is sort of how early can you start integrating cost analysis in your implementation strategy studies. And some people have gotten pushback that they're doing it too early, but I think it's actually good to do that as early as you can, if you can get away with it in grants.
Great. So we have 2 minutes left in the session. So I'll give you one more question, but it's going to have to be a speedy response. So can you kind of very briefly give another example of an adaptive strategy?
Yeah. Andrew, do you want to, since you're doing this work, do you want to give your example?
Sure. I guess an adaptive strategy, I'm going to give a very quick overview because we can talk more about it in the next panel, but would be, for instance, we have a bundled strategy called systems consultation, and we're testing it in a sequential multiple assignment randomized trial in a way where we can sort of start with a system level strategy, which we're defining as educational meetings with audit and feedback. So it's basically drilling deeper and deeper from the system level to a clinic level to an individual prescriber level. and then assessing cost effectiveness and outcomes progress along the way. That's how we're kind of conceptualizing it. Now there's lots of different ways you can do an adaptive strategy, but I think the idea there, sort of the analogy, is that a skilled clinician, if you're treating a patient with depression, for instance, I'm not a clinician, so I'm probably getting it in over my head very quickly, but you might try one approach like cognitive behavioral therapy and see if it's working. And if it's not, you might say, okay, well, let's now try some antidepressant medication, and then keep monitoring for effect. You could sort of analogize that to implementation strategies. And a lot of times it makes sense to start with kind of the lower touch strategies. And then if it's not working, provide more and more support. And that's one way of doing it, but that's certainly a 2-minute answer to a very, we could spend a whole day or a whole conference discussing that topic.
Definitely.
So
thank you for giving that brief. I just saw it asked many times on here and thought a little bit of clarification would be helpful. So thank you very much.
Also, just real quick, I did put a reference into one of Amy Kilborn's papers that is an implementation example of a SMART trial.
Yep. Her work has been an inspiration to me, and her work with Danny Almerel, who's a co-I on our study. So they're doing great work.
So it is now
time for the break then?
Yes.